Our lecture for this afternoon would be cardiac diseases in pregnancy. Objectives for this lecture would be to discuss the normal physiology during pregnancy, cardiac testing, and common cardiac problems that we encounter in pregnancy. So this is a summary of the normal pregnancy changes in your cardiocirculatory system. So your systemic arterial pressure begins to fall during the first trimester, nadir in mid-pregnancy, and eventually returns to normal before term. Reduction in blood pressure is related to decline in your systemic vascular resistance, which is mediated by your gestational hormones such as your prostaglandin. There would be increased heat production by fetus, which is created by your low resistance circulation. So changes in blood volume during pregnancy are attributable to estrogen-mediated stimulation of your renin-angiotensin system. Changes in other hormones such as your deoxycorticosterone, prostaglandins, estrogen are also causes of water retention, thus increase of your blood pressure or cardiac changes. So your plasma volume would increase by 50%, and this would lead to your physiologic anemia of pregnancy. Cardiac output increases by 50%. So this begins as early as the 5th week till the 24th week, then eventually plateaus or slightly increases. In early pregnancy, the increase in cardiac output is secondary to the increase in stroke volume, while in the third trimester, it is related to increase in heart rate. So you would see again the changes in normal pregnancy. So you have to take this in mind when we discuss your abnormal changes in pregnancy and know the normal at the back of your hand. So the hemodynamic changes during labor and delivery are due to the following. Of course, the mother would feel anxiety and pain, would feel pain during uterine contraction. There would be increased oxygen consumption as much as threefold, increase of cardiac output during labor due to increased stroke volume and increased heart rate, increase of your systolic and your diastolic blood pressure, especially during the second stage. These changes are influenced by the form of anesthesia and analgesia, which also important when we deliver the fetus. Postpartum, there are also hemodynamic changes. Of course, when the fetus is removed from the uterus, there is your increase in venous return because of relief of your venocaval compression. So the blood shifting or autotransfusion because your uterus contracts and goes back to your systemic circulation. This would then give a negative feedback aided with the blood loss during delivery and would effectively increase the effective blood volume. So there would be a substantial increase in your left ventricular filling pressure, stroke volume, and cardiac output, and may lead to clinical deterioration. So to assess a patient that is pregnant with cardiac problems, it is always important to take a thorough history and physical exam, focusing on the exercise capacity, current or past evidences of heart failure, and any associated arrhythmias. do your physical exam, and look for your cardiac hemodynamics and assess the severity of heart disease. Do an echo, MRI, ECG, exercise testing so that you assess the functional capacity. Ideally, this is done before conception. However, with the health-seeking behavior of our patients, we usually see them already pregnant. During pregnancy, we have to evaluate once each trimester and whenever there would be changes in symptoms. And of course, we have a multidisciplinary approach. We involve our cardiologist, anesthesiologist in the plan of the pregnancy. Fetal echo also has a part in assessing during pregnancy. During labor and delivery, of course, we maintain that multidisciplinary approach and we tailor management to specific needs of the patient. There are some signs that may mimic cardiac disease. A loud S1, exaggerated splitting of S2, a physiological S3 at the apex, a systolic ejection murmur at the left sternal border at least a 3/6, a continuous murmur, bounding pulses, and ectopic beats could be normal in pregnancy. We suspect heart disease if we encounter low volume pulse, tachycardia, cyanosis, clubbing, and splinter hemorrhages, any sign of cardiac failure, and pansystolic, diastolic, late ejection, and late systolic murmurs. So your New York Heart Association provided a classification so that we could assess heart failure. It is classified into class 1, 2, 3, and 4, with class 1 having no limitation, class 2 having slight limitation, class 3 having marked limitation, and 4 with severe limitation during physical activity. In your electrocardiogram, these are accepted changes in your ECG. Anything other this would be an abnormal electrocardiogram in pregnancy. So a left axis deviation is normal up to 15 degrees because of the elevated diaphragm. A reduced PR interval, inverted or flattened T waves, and Q wave in lead 3. On radiography, there would be cross cardiomegaly. You know that there would be a slight increase in your cardiac size due to the distance due to pregnancy. For 2D echo, there would be a small increase in all chambers. That's acceptable. In addition to the New York classification, there would be predictors of heart failure. Prior heart failure, transient ischemic attack, arrhythmia, stroke, a functional class of 3 or 4, or cyanosis, left-sided obstruction defined as a mitral valve area less than 2 cm squared, aortic valve area of less than 1.5 cm squared, or peak left ventricular outflow tract gradient greater than 30 mm mercury. Ejection fraction of less than 40%. The WHO furthermore classified cardiac disease and pregnancy with risk class 1, 2, 3, and 4. Risk class 1 would be no detectable increased risk of maternal morbidity and mortality. Risk class 2 would be small increased risk of maternal morbidity and mortality. Risk class 3 would be significant increase of maternal morbidity and mortality. And 4 would be extremely high risk of maternal mortality and severe morbidity, included in the risk class 4 would be pulmonary artery hypertension, peripartum cardiomyopathy, severe systemic ventricular dysfunction, Marfan's, and native severe coarctation. So this would constitute a high-risk pregnancy as mentioned in the previous slide. Pulmonary hypertension, Eisenmengerization, systemic obstructive cardiac lesions, Marfan's, systemic ventricular dysfunction, severe cyanotic heart disease, patients with prosthetic valves, and significant uncorrected cardiac heart disease. So this may be considered contraindications to pregnancy because of your maternal death rate as high as 50% in your severe pulmonary hypertension, severe obstructive lesions, and your systemic ventricular dysfunction. Although the prevalence of clinically significant maternal heart disease is low, which is at less than 1%, its presence increases the risk of adverse maternal, fetal, and neonatal outcomes, such that there is a study, which is a cardiac disease in pregnancy, enrolling 563 consecutive women with heart disease, and outcomes were determined in 599 pregnancies not ending with miscarriage. So these are the adverse maternal cardiac events. So the outcome occurred in 4% of the women with none of these risk factors, 27% in those with one risk factor, and 62% in those with more than one risk factor. So we have your pulmonary edema, brady or tachyarrhythmia, stroke, cardiac arrest, and death. Secondary would be worsening of your functional class and need for urgent invasive cardiac procedures. So for the neonate, what happens is there is a high risk for premature birth, small to gestational age birth weight, respiratory distress, intraventricular hemorrhage, and death. So these are the cardiac tests performed. We have your Doppler echocardiography, stress testing, radiation of the embryo. If age 0 to 10, there's no effect. Age 10 to 50, there may be teratogenic effects. Age 50 to delivery, you have your IUGR, CNS abnormalities, and increased incidence of childhood cancer or leukemia. So your routine chest radiography delivers 20 rads, and your standard fluoroscopy delivers 1 to 2 rads per minute. So current recommendation falls at greater than 5 rads, very low risk, 5 to 10 rads counseling for low risk, 10 to 15 rads during first 6 weeks, would depend on the individual, and greater than 15 rads, ideally termination of pregnancy. MRI could be used. Catheterization helps in managing your high-risk patient during pregnancy, labor and delivery, and cardiac catheterization can be done. So your pulmonary hypertension, as you know, is a functional class 4, and it's really a risk for adverse outcome. Of course, when your Eisenmengerization sets in, you have your right to left shunting, so there would also be an increased rate of maternal events due to your pulmonary hypertension. Your systolic pulmonary arterial pressure is greater than 75% systemic pressure. there would be an increase in intravascular volume, which would lead to heart failure because your cardiac output is limited by your pulmonary vascular disease and ventricular dysfunction. The decrease in your systemic vascular resistance, especially after the first trimester, would further worsen your right to left shunt and lead to cyanosis and further exacerbated during labor and delivery. So ideally, we put this to bed rest, oxygen, use anticoagulants, and cesarean section is recommended with invasive monitoring and early ambulation. Severe aortic stenosis is poorly tolerated. Mortality could reach up to 17%. So symptomatic patients are advised to delay conception until after surgical or interventional correction. We can consider balloon valvuloplasty or your Ross procedure. Systematic patients before end of first trimester, if termination of pregnancy is allowed, beta blockade or bed rest, palliative aortic balloon valvuloplasty, or early delivery. So prosthetic valves and pregnancy, there is an issue of anticoagulation. So warfarin versus heparin. So warfarin, as we know, crosses the placenta, can cause early prematurity, embryopathy when used in the first trimester, CNS and eye abnormalities, and bleeding in the fetus, and should be stopped before delivery. So there's a warfarin embryopathy, that is nasal hypoplasia, bone epiphysis, optic atrophy, blindness, seizures, with an overall risk of 5%. So this decreases with the use of unfractionated heparin in the first 3 months. So the recommended anticoagulant for pregnancy is low molecular weight heparin because it does not cross the placenta, it is not teratogenic, does not cause fetal bleeding. So heparin is a twice daily subcutaneous injection, although there's risk of osteoporosis and risk for thrombocytopenia. And this is dose-dependent complications of warfarin in pregnant women with mechanical heart valves, so avoid warfarin as much as possible. So, of choice would be unfractionated heparin, 4 times, although it would have a 4 times higher incidence of your thromboembolism during pregnancy than your oral anticoagulants. So failure to adjust dose of your heparin to prevent thromboembolic phenomena in pregnant women with mechanical valve prosthesis. So although adjusted doses of your heparin does not improve outcome and increases maternal mortality. So this is your complications during pregnancy using anticoagulants. So your vitamin K antagonist throughout pregnancy may lead to embryopathy, spontaneous abortion, thrombotic events, maternal death, etc. Heparin throughout pregnancy, either low dose or adjusted dose, and heparin during your first trimester. So we add your low dose aspirin, particularly in women with high-risk valves, patients with cyanosis, patients with intracardiac shunts, women with previous transient ischemic attacks and or strokes, and women with atrial fibrillation. So low molecular weight heparin will not also cross the placenta and is better because it does not require frequent PTT monitoring and has a longer half-life than your unfractionated. However, data is less available for your low molecular weight. and successful use is already reported in small number of patients, although there are some cases of treatment failure as well. So at this time, should not be recommended at the present for patients with heart valve prosthesis during pregnancy. So for mechanical valves and anticoagulation during pregnancy, heparin may not prevent valve thrombosis. Adequate anticoagulation may be difficult. Heparin may produce osteoporosis. There's little data regarding your low molecular weight heparin. Warfarin can cause embryopathy. And aspirin is safe but probably beneficial. So this would be anticoagulation algorithm for patients with mechanical prosthetic heart valves. So higher risk would be your first gen prosthesis. You use your Coumadin. Lower risk, you use your heparin and Coumadin with regimen as follows. So for cardiac patients, mode of delivery, so vaginal delivery assisted, facilitate your second stage to shorten the second stage of labor, and it's the preferred route unless there would be other obstetric indications. We use invasive hemodynamic monitoring only in severe valve stenosis, recent heart failure, severe cyanotic heart disease, and pulmonary hypertension. Cesarean section, on the other hand, avoids your physical stress of labor but is not free from any hemodynamic consequences. Indications in CHD to do cesarean season would be for obstetric reasons, therapeutic anticoagulation with Coumadin at the onset of labor, pulmonary hypertension, unstable aortic lesion with risk of dissection, severe obstructive lesions. So breastfeeding is encouraged in women taking anticoagulants. Heparin is not secreted in your breast milk and the amount of warfarin is low. So we have our endocarditis prophylaxis before we give your endocarditis prophylaxis left and right. However, now it is reserved for those with prosthetic heart valves, with previous endocarditis, valvulopathy, and unrepaired lesions. Regimen of your prophylaxis will be as follows: ampicillin 2 gram or your cefazolin or ceftriaxone 1 gram. If it's penicillin allergic, it's your cefazolin or ceftriaxone or clindamycin 600 milligrams. For your American Heart Association, it's your amoxicillin 2 grams or ampicillin 2 grams. Penicillin allergic would be clarithromycin or azithromycin, along with your clindamycin, cefazolin, and ceftriaxone. In conclusion, most women with heart disease can have a pregnancy proper care, and pre-pregnancy evaluation is prudent. High-risk cases benefit from combined high-risk obstetric and cardiac care in the same center. So references of this lecture would be Chapter 49 of Williams, Obstetrics 25th edition. Thank you for listening to this lecture. Please subscribe to my channel for more lectures on obstetrics and gynecology.